ERCP plus endoscopic ultrasound-guided biliary drainage versus percutaneous transhepatic biliary drainage for malignant hilar biliary obstruction, a multicenter observational open-label study. Introduction. Current palliative biliary drainage methods for patients with bismuth correlate class 3, 4, or more advanced malignant hilar biliary obstruction, MHBO, are not perfect. An ideal drainage procedure would be minimally invasive, with internal placement, and offer adequate biliary drainage, defined as draining more than 50% of the liver volume. Unfortunately, currently available procedures cannot meet these ends. Surgical bypass is relatively invasive for patients such as these, who typically have short survival times. Endoscopic retrograde cholangiopancreatography, ERCP, with multi-segmental drainage is technically difficult due to the tightness of strictures, and selective intrahepatic bile duct IHD cannulation is also challenging. A recent guideline from the European Society of Gastrointestinal Endoscopy, ESGE, recommended percutaneous transhepatic biliary drainage, PTBD, or a combination of PTBD and ERCP as palliative biliary drainage procedures for bismuth types 3 and 4 MHBO. However, PTBD is inconvenient for most patients because of the associated external lines and bags. Endoscopic ultrasound-guided biliary drainage, EUS-BD, has been increasingly used worldwide as an alternative when ERCP is not possible or fails. Most studies have focused on utilizing EUS-BD in patients with distal bile duct obstruction, and information about EUS-BD for patients with MHBO is limited. Nakai et al. Recently reported that among 88 patients with MHBO treated with EUS-BD, the technical success rate was 98%, the clinical success rate was 77%, and the complication rate was 8%. EUS-BD was performed as either a primary biliary drainage method or a rescue method after failed ERCP. Given the lower clinical success rate and higher complication rate of EUS-BD in MHBO compared with ERCP, it should not be considered as the first choice for palliative endoscopic biliary drainage. As ERCP with stent placement is simpler for drainage of single rather than multiple segments, we hypothesize that combining ERCP and EUS-BD procedures as a primary biliary drainage procedure in patients with MHBO would ensure more complete emptying of the undrained segments. Transmural EUS-BD, including EUS-guided hepaticogastrostomy, EUS-HGS, and EUS-guided hepaticoduodenostomy, EUS-HDS, can be performed following ERCP with biliary stenting in right and left IHDs, respectively, in order to accomplish adequate internal biliary drainage for MHBO. As ESGE has recommended PTBD, or a combination of PTBD with ERCP, as the procedure of choice for biliary drainage in patients with MHBO, Kongkam et al. Aim to compare the benefits and harms of biliary drainage using a combination of ERCP and EUS-BD against a historical control group treated with PTBD as a primary biliary drainage method in this prospective cohort study. Methods. Patients with MHBO undergoing endoscopic procedures, Group A, were compared with those undergoing bilateral PTBD, Group B. The primary outcome was the 3-month RBO rate. Results. 36 patients were recruited into Groups A, N equal 19, and B, N equal 17. Rates of technical and clinical success and complications of Group A versus B were 84.2%, 16 of 19, versus 100%, 17 of 17, P equals 0.23, 78.9%, 15 of 19, versus 76.5%, 13 of 17, P greater than 0.99, and 26.3%, 5 of 19 versus 35.3%, 6 of 17, P equals 0.56, respectively. Within 3 and 6 months, RBO rates of Group A versus Group B were 26.7%, 4 of 15, versus 88.2%, 15 of 17, p equals 0.001, and 22.2%, 2 of 9, versus 100%, 9 of 9, p equals 0.002, respectively. At 3 months, median number of biliary re-interventions in Group A was significantly lower than in Group B. Interquartile range 0 to 1 versus 1 range 1 to 2.5, respectively, p less than 0.001. Median time to development of RBO was longer in Group A than in Group B. 92, range 56 to 217, versus 40, range 13.5 to 57.8 days, respectively, p equals 0.06. Conclusions. Combined ERCP and EUS procedures provided significantly lower RBO rates at 3 and 6 months versus bilateral PTBD, with similar complication rates and no significant mortality difference.